give me a thumbs up whenever.
Excellent. Well, welcome everyone to our MEP pop-up learning series, Critical Care Updates 3/31/2020. Very pleased to have Rory Spiegel back to provide us with important critical care updates. Everything has been moving at such lightning speed. A lot of things have changed even since our prior pop-up learning sessions. In following Rory giving us some highlights regarding what we're seeing, where we are, some of the triage protocols, as well as where we're headed. We're going to open it up for a panel discussion, and Rory will be joined by Shane Kapler and Manish Goyal from our EM Critical Care Medicine, EM Critical Care Division section to talk about some of the important issues that we're all grappling with in the emergency department. So Rory, I'll turn it over to you.
Yeah, so we thought we could just give a couple updates first. I think that the big reward here is going to be in the panel discussion. But, you know, as this is progressing, you know, it's very rarely that I've seen a disease process that we know so little about and how quickly it's progressing. And it's become clear essentially since last week that this is not the disease we anticipated it is. In fact, to start, it's not ARDS at all. In fact, I would say if you have someone with ARDS, it might not be related to COVID, but when you intubate them, there's something else going on. When you put these patients on the ventilator, their compliance is normal. And so they have this exquisite hypoxia, and their PDAF ratios are very low. And you know, in our prior discussions, we've kind of talked about PDAF ratios as this concept of a way to quantify how much of the lung is derecruited and atelectic, and how much of the lung is actually participating in ventilation. And we talked about that baby lung. And the lower your PDAF ratio, the smaller of your baby lung, and this idea of protecting that baby lung through low tidal volume ventilations. And so you have these patients who are really hypoxic, their PDAF ratios are really low, and you intubate them and put them on the ventilator, and their compliance is normal. They all have plateau pressures way below 30. And there's something else going on that I don't think we quite have figured out yet, whether it's some abnormality of the vasculature and you have really bad VQ mismatch, or it's something at the venous alveolar side that's causing this, or diffusion deficit. We're not exactly sure. But I have to think that we're going to have to start moving away from thinking of this as ARDS and moving towards thinking like it's something else. And so that's kind of the first thought of this. And I think we'll start understanding more and more of that as we go forward. So I thought we could look at our triage protocol, which I think everyone can see. I know there were some questions over email, and a number of us, including Shane and I, develop this with some of our critical care colleagues, and it's mostly a guideline of what to expect and kind of phenotype or triage these patients as their risk of decompensation. And I think it actually still stands quite well over the last week as we've seen more and more of these patients. And so what you're seeing here, this low-risk group is essentially all the walking well who look really good, and those are the ones that get to go home. The real thing here that I think differentiates these ones from the ones that are at risk and should come into the hospital of decompensation is the O2 sat and the ambulating, desaturation during ambulation. What we've seen is these patients will go from being on room air to being on high levels of oxygen, being intubated within a day, less than a day, within 12 hours. And the ones that we've really identified are the ones that looked well and then desaturated during ambulation. So I think respecting hypoxia, whether it's during walking or just at rest, is one of the key things that identifies the patients that are pretty sick. And so that's kind of looking at that low risk group. When you go to the moderate and severe risk groups, it can be a little confusing when you first look at it. But what I really wanted to differentiate are the two kind of criteria we've broken this down with. And one is simply oxygen requirement. So resting hypoxia or ambulated desaturation. That is a high risk group and should be admitted to the hospital. And then the patients who, despite oxygen, are still not able to maintain their SAT. So the severe risk group right here are a very high risk group that need some form of IMC or ICU evaluation and probably put somewhere where someone can keep an eye on them, right? So these two components I think are the most important, and I think they will continue to be the most important the more we see these patients have an understanding. These boxes right here, what I'm circling, can everyone see that? So any two of the following or any three of the following are far less certain. They're not really known. And this was a compromise with our critical care colleagues and kind of looking at the CURB 65 and using that to try to apply to these patients with the thought that if you're older and have some other comorbidities and have a high respiratory rate, you're at a high risk. So you might not meet our primary triage criteria, but you should still stay in the hospital or get evaluated by the ICU. And that's kind of where those things stand. I think they'll be far less useful as we go forward, and most of our decisions will be made off these two groups here. But we left them in for now because we just don't have enough familiarity with the disease process to say they're not going to be helpful. And then finally, the last group is fairly easy, right? These are the ones who are really, really sick and need the ICU and possibly intubation. So you want to stop and pause if anyone has any questions about the triage document?
If you have any questions that come up about the triage document, please feel free to chime in via chat. We have a question that came in. We have a pretty significant patient population that does not ambulate at baseline. Are there other maneuvers people are trying to do a mild cardio challenge?
That's interesting. I never thought of that. So are they getting around with a walker or wheelchair?
Yeah.
Yeah. I mean, I think it's hard to know. Honestly, I think a lot of those patients would fall into this group that would be fairly concerning. The idea that you have someone who can ambulate at baseline and may not be able to be watched at home is obviously somewhat concerning, and that would put them at a higher risk group. But it's without stressing them, I think it's hard to really find your primary output. I think, as things get tight and we can't admit everybody, having some ability to follow up on someone who is satting well, even if you can't ambulate them, as long as they can follow up, it's probably something that you could safely discharge. I don't know if you could do like an arm ergometer or something, but that is obviously going to be something that's limited in the emergency department.
Great question there. And so why don't we go ahead and, Rory, if it's okay with you, we'll go ahead and transition into some of our panel discussion topics.
Yeah, I just wanted to bring up one more thing before we go. I'm sorry.
Great.
Yeah, the final thing I wanted to say is, what we've been talking about and what we heard early from Italy and China was intubating all these patients early. And our current recommendation, say after 6 liters and maybe up to 10 in a non-rebreather, you move towards intubation. What we're seeing ourselves and what we're hearing out of New York is that might not be the best idea. And some of these patients can be bridged with the use of high flow nasal cannula. So what we have in the works right now is a high flow nasal cannula protocol that's going to be going through the kind of pathway to get approved and will probably be rolled out later this week, hopefully. And so when it does, we can meet back and we can actually have a session specifically talking about the details of how you implement high flow nasal cannula and how it's safe. But I want to give everyone a heads up that's probably the way we're going to be moving, that maybe not early intubation is the best thing for these patients, and moving towards some other kind of non-invasive support may actually help a good subset of these patients.
Great, and that's going to launch right into the first item for our panel discussion. And so, Manish, if you wouldn't mind unmuting as well, and I don't know if Shane has joined us yet. I see Shane on there as well. If you wouldn't mind unmuting, and we're going to talk a little bit about non-invasive ventilation and just kind of do a deeper dive into NIV. The initial approach, the initial thought was that we should be avoiding this because of spray, and then risk to healthcare providers, risk to those in the environment, our teams. But the conversation has really evolved and pivoted and adapted since that time. And if we can start with you, Manish, and talk a little bit about what you've seen, what you've heard, and how that message has pivoted over the last week or two.
Yeah, I mean, I want to start with just saying that I think we have to be very cautious about how we apply the data that we've learned from Italy and from China, because I think that both phenotypically and genotypically, those patients are very different than what we see in our population. And I think we should be cautious about stepping away from practices that historically have worked. And speaking specifically of BiPAP, so we've talked about the 2 different setups of BiPAP, the single limb with a traditional non-invasive vision device that we use and the double limb with the PB840 ventilators, and know that our RTs know how to set up both devices with viral filters. So both of our devices are set up to be used with viral filters. I've intubated 4 patients now, I think had COVID, certainly at least were high risk for COVID. All 4 of them, I used BiPAP beforehand. And I think that that should be our practice, where, these patients are coming in profoundly hypoxemic, and getting them on BiPAP gives us the opportunity to stabilize them and get a little bit more data. And so I think we have to be very careful of the messaging of not using BiPAP. I understand from the intensivist perspective of keeping somebody on BiPAP for a prolonged period of time may not be the right thing to do. Maybe, we don't know. But I think from the emergency department perspective and using it to stabilize our patients, I think we should continue to do that.
Yeah, I think that's a great point. I think it also brings up the point that, it's easy as an intensivist once you have a kind of a clear diagnosis and what's going on and you're in the ICU, but in the ED, we don't often see that. And I think we're going to talk about, applying non-invasive to patients that we know it works on, but may or may not have COVID. As long as you apply it with the kind of the qualifications that Manish discussed, you can apply it reasonably safely, and it gives you time to figure out whether this is COVID or is this heart failure and you have flash pulmonary edema or something of the sorts, and you can kind of figure that out as you go, and you can do it in a reasonably safe situation.
So Shane, any thoughts that you want to add as well?
Yeah, no, I mean, I think the takeaway, I mean, I was late because, I was just on a hour-and-a-half call of, sort of wrestling with the idea of high flow. And I think that the takeaway is that, this is a novel disease. And I think the most striking thing that we're learning, especially from our colleagues in New York City, is that it's not behaving the way that we have sort of this phenotypical prototype of sort of, pneumonia causing respiratory failure. And it really is not behaving in that way that we're used to really at all. And so I think that this is, trying not to be dogmatic and not take away any tools, while also recognizing that there are concerns about aerosolation. So trying to do things in the safest possible way. And that's our sort of our approach. And I think we're getting sort of more experience with it. And I think the initial thought was, okay, well, a couple months ago, if we have a few of these patients, we'll intubate them early, we'll have it controlled, and, they'll get, sort of get better and this wave will pass. That's obviously not the situation we're in anymore. And so we need to start developing tools where we can take care of patients, but do it safely. So just sort of a little bit of the caution of, not being dogmatic as we approach any of these therapies, and recognizing that because it's novel, we're going to be evolving through this, I think, for a while.
Excellent. And a question that came in is, if we are doing this, are you going to obtain a helmet or some other way to contain aerosol in the case of mask leak with BiPAP?
Yeah, I think that's a good question. And Rory and Shane would love to hear your thoughts. But my thought on that is when we're doing this, we're treating it with complete precautions. Everybody's wearing an N95, everybody's fully gowned. And so I think the risk of leak is relatively small. It's really just if the mask comes off. But I want to point one thing out about that. When we move over to the vent-based BiPAP, it's important to recognize that those pressures are additive as opposed to independent. So if you set a Respironics Vision device, if you ask the therapist to set it at 10/5, that's an inspiratory pressure of 10 and an expiratory pressure of 5, which gives you a driving pressure of 5. If you set a PB840 vent at 10/5, it's going to say 10/5, but it's going to deliver an inspiratory pressure of 15 and an expiratory pressure of 5. So that 10 is the driving pressure, and it's additive. And I bring that up because 2 out of the 3 people that we used this on, the respiratory therapist had set it at 15/5, which meant the inspiratory pressure was 20 for both of those patients, which is generally higher than we would use and was creating a leak. And I think that creates more, I have more concern over that than I do over using a regular BiPAP device at say 10/5.
I think that's great. Yeah, when you actually look at the data on aerosolation and BiPAP, the biggest risk isn't the leak. The two areas, if you don't have a viral filter and you're kind of shooting air that hasn't been filtered through the circuit and out the other side, and then the other time is if the patient pulls the mask off. And that's the biggest concern why you wouldn't use BiPAP long-term on these patients, because of the risk of aerosolization if the patient pulls the full mask off. And that's why moving towards high flow is probably a better kind of long-term non-invasive advice. When we're in the room and we're using this in an active resuscitation, that's a different step, right? You can control those situations for a short amount of time as long as we do it in the safe way that Manish described, where you're actively filtering the exhalation port and then you're making sure the patient doesn't pull the mask off. You have a relatively safe circuit.
And one of the initial thoughts was that intubate early, place on a vent. It is the safest circuit for decreasing aerosolization, getting to the root of the issue, which is generally hypoxemia. But there's a thought that's been emerging that saving vent days, right? If we can bridge somebody on high flow BiPAP, and ultimately, if we know that their lungs are going to be really, really sick for 2 weeks, if they're bridged on non-invasive for a period of time before they ultimately get intubated, does that help? Does that hurt? And so some comments regarding that.
Yeah, again, this is with the caveat that I don't think we know just yet. But, the more and more we see it, it's not ARDS. The hypoxia is from something else. And so putting them on the event with the idea that you're going to recruit lung and protect lung volumes may not be the best thing to do. And so using a high flow nasal cannula, one, the initial thought is not only does it prevent vent days, it also limits the amount of ICU resources you need. So having a whole bunch of these patients on high flow, it's much easier to manage than having a whole bunch of them on the ventilator. So you can prevent vent days, and you can actually cohort them somewhere where you don't need quite as much ICU resources. So that's the first step. The second thing is some of them, from what we're hearing from New York, actually make it through, so that you never required intubation. So there's some of them that you can kind of ride through in high flow, accepting mild hypoxia and pretty high flow settings. They can actually make it through without intubation. And so you might actually salvage some patients that way as well. And then the third thing is that we don't know yet, is the vent actually doing harm in some of these patients? And that we don't have really good data, but we are seeing this idea that you have a single organ problem where patients come in with hypoxia but are talking to you and they're relatively comfortable despite that hypoxia. And then when we intubate them, they start having other organ failure. You have to use a lot of sedation to keep them controlled. And obviously you could have some iatrogenic harms going on.
And a couple of questions that are filtering in. Read something about using CPAP instead of BiPAP. Any thoughts on that? And related, are we able to prone patients using high flow nasal cannula?
You're speaking to, yeah. So we'll do the CPAP question first. There's a thought. I preferentially like CPAP almost in all my patients. I think when you're talking about standard respiratory failure, most of the issue is you have this de-recruited lung. And so it's much harder to breathe because your lung volumes are small, your diaphragm's not at its optimal position. And if you can use CPAP to re-recruit lung and get people back to their resting lung volumes, just allowing them to breathe on their own is probably okay. I manage a lot of patients on the ventilator actually with CPAP alone. This disease process, I don't know. It's not ARDS. It's not de-recruited lung. They probably don't need the BiPAP support because, again, their lungs are functioning well and they have a normal diaphragm. So I think CPAP is fine from that standpoint. It might limit the amount of lung injury you produce since you're not pushing more air than they need into them. But I'm not sure if either one is beneficial from treating the actual pathophysiology of the disease. As far as proning, so this is going to be part of the protocol we're rolling out from a suggested standpoint. There's one study, I think, out of Singapore where they did it in COVID patients showing success awake high flow nasal cannula plus proning. And there is a small kind of set of data on non-COVID patients with pneumonia where you awake prone them and they tend to do better. Very limited data though. But it sounds a lot scarier than it is. It's essentially you have to have a cooperating patient, right? So this is someone who's awake and alert and talking to you. And the nice thing about this COVID cohort is they are awake, alert, and talking to you despite pretty profound hypoxia. And you're literally just asking them to turn onto their belly. And so you don't want to be taking someone and just like who's in a coma and hoisting them over. This is something where they have to be able to do it, and they have to be able to be awake enough that they can turn back over when they feel uncomfortable. One of the big things about starting a proning protocol for ARDS, because these patients are going to be sedated and often paralyzed, is you have to be able to turn them before they get ulcers on their face and on their other parts of the front of their body. And when you're awake, you don't have to deploy that kind of protocol because the patient can do it themselves. But you have to make sure these are awake patients. You can't do it. You can't add sedation to help them, and they have to be able to flip themselves back over when they no longer feel comfortable in the prone position. But when you take those considerations in mind, it's actually fairly safe and fairly easy, right? Because you're literally just asking the patient to flip over, and then you say, hey, why don't you sleep on your belly instead of sleeping on your back at night? And the other thing that we're kind of offering in the same sense is to sit people up, don't have them lie on their back all the way down. So when they're not in prone, really sit them upright as possible. And then we're also recommending having incentive spirometers in the room and just trying to really encourage the patient to use that as often as possible to try to limit the amount of de-recruitment that they get.
And that's especially for people that might be down in the ED for 4 to 5 hours, maybe even getting that started, which is not something we typically think about doing, in our current practice. And just to go back to answer the CPAP question, just to add to that, I think where that's coming from is, there's a thought that CPAP is going to provide sort of the maximum mean airway pressure comparatively to BiPAP, right? So if you set your BiPAP at, we were talking about in terms of like your IPAP is 20 and, your EPAP is 5, right? Whereas you set your CPAP at 20, your mean airway pressure is going to be higher there on the CPAP, right? Because it's delivering 20. Whereas you're having that sort of flow up and down with the BiPAP between the EPAP and the IPAP, and your mean's actually lower. So that's where that sort of CPAP is better, is coming from, is sort of the physiologic reason on how you're actually delivering the pressure.
And switching gears a little bit to out-of-hospital cardiac arrest. I know this question has come up, and you all have brought up very important points about the phenotypic differences, almost the disease differences that we're seeing nationally, domestically, compared with the worldwide experience. We are starting to see out of other cities within the U.S. Out-of-hospital cardiac arrest protocols, strategies, approaches. So starting with you, Manish, if you want to just kind of lead us through some of the current thoughts and suggestions of how we should be tackling this very sick patient cohort as they're presenting to us.
Yep. So one quick BiPAP CPAP comment, John, if you don't mind.
Sure, please.
I think we have to remember why we're using either mode. And CPAP is, to go back to what Rory said, it's just to recruit. It's just for hypoxemia. We're adding that inspiratory pressure usually to decrease work of breathing, increase ventilation, and more often than not, these patients are ventilating fine. So I think having an adequate CPAP and maybe adding a little bit of inspiratory pressure, sometimes you need that, sometimes you don't. So CPAP may work out just fine. And to dovetail on one thing Shane said, one of the things that we can be doing with every one of these patients that intubate, and frankly, I haven't seen this done yet, we need to sit them straight upright. If we're intubating these patients, we cannot let them lay on their backs. When we paralyze them, particularly if we use rocuronium, their liver pushes up in their diaphragm and they collapse those posterior inferior lung segments, and we're making their shunt much, much worse and much harder to recruit. So as soon as you intubate the patient, as soon as that tube's secured, sit them upright, and that's going to help them recruit quite a bit. Now, to talk about cardiac arrest, I think, first and foremost, I think we have to assume that every patient that comes in is a PUI, and we have to protect our teams to that end. And so that means minimizing staff when patients come in. It means keeping the Lucas device on if they already came in with a Lucas device. Everybody should know that every department is going to have a Lucas device. I think by the end of the week, every one of our emergency departments will have a Lucas device, and we'll post a video on how to set it up and how to use it on the MEP YouTube site. I think everybody has to be in PPE. I think we're already doing those things. And then there's going to be other subtle changes, like ensuring that you've got a viral filter on the ambu bag, ensuring that you stop compressions when you're, if you choose to put an ET tube in. And then maybe the biggest thing is considering whether or not you should be resuscitating this patient at all. You know, particularly for our clinicians that work in DC. DC has relatively conservative termination of resuscitation algorithm in that if anybody gets a perfusing rhythm back, that means every PEA, theoretically, anybody who goes from asystole to transient PEA, according to, depending on how you interpret DC's algorithm, that person should get brought into the hospital. I think that that's probably overly conservative, particularly with all that's going on. I think we probably should be pronouncing these patients on arrival. I think something that's up for us to discuss is, should we meet our EMS colleagues, you know, kind of at the entrance to the emergency department, hear the story, and if somebody has an unwitnessed, non-shockable arrest that's pulseless despite EMS's efforts, I think we should pronounce them before they even make it through, just to prevent aerosolization throughout the department. But we'd love to hear others' thoughts.
I think your last point is key. I think the biggest here is being far more strict with our termination of resuscitation kind of guidelines. The data is pretty clear that if you're unwitnessed, no bystander CPR, and you've made it to the hospital without a pulse, your chance of survival is next to zero. And so you could make a big difference in the amount of patients that you could have to expose yourself and your staff to if you just simply say those patients are non-survivable and not worth the risk. I think that's probably the biggest thing we can do, but the rest of the protocol is also fantastic.
Shane, any thoughts, Dad?
No, no, I think Manish and Rory kind of really hit the key points of that.
A question that had come up that Carrie had posed is whether or not to change the King airway on these patients when they come in. Let's say that you're not pronouncing these patients. I think it's a great question, and what I would say to that is it depends on how long I plan to attempt resuscitation efforts, and whether or not I have an end-tidal CO2 waveform. If I've got a good waveform, particularly if I'm thinking about pronouncing them sooner rather than later, I don't think that I would change over that ET tube. You can make the argument to not change it over at all if you've got a good end-tidal CO2 waveform. I don't know if there's the potential for more aerosol generation with King airway or supraglottic airway versus an ET tube. I suspect there probably is. So if I take the scenario of a young person with a witnessed VF arrest who transiently gets return of spontaneous circulation, I'm probably going to change that over to an ET tube. But if I am debating stopping sooner with the King airway and I've good capnographic end-tidal CO2, I'm probably not changing it over.
And a related question that came in is, do we know if there have been any changes to DC Fire and EMS protocols and approach to airway in out-of-hospital cardiac arrest? Are they using viral filters? Are they still utilizing King airways? And Manish and several others, I know you've been in touch with Ryan Garrett, who is now one of our attendings at Hospital Center, who also is one of the deputies for DC Fire and EMS.
Yeah, we had reached out to Ryan and also communicated with Lauren with several recommendations, including not using nebulizers, certainly not using nebulizers through the department, trying not to use BiPAP. And what we heard back was these all make sense. This is in line with national recommendations. And we've got a lot of providers, so it'll take some time to change. So I can't speak to the specific changes that have been made.
One of the questions that came in prior to our VOD cast here is we are starting to see really sick CHFers, kind of our standard CHF exacerbations that we see in the ED, who are hypoxic, probably more from staying away from the ED to avoid coming in and being exposed to other PUIs and COVID-related illness. Any tips for clinical judgment on who we can BiPAP for CHF, just like we did in the old days, versus kind of this newer thinking and approach that we have, and all under the umbrella of presuming that everyone is a PUI. And I guess the same thing goes for steroids and other sort of standard treatments for COPD and other illnesses. And how should we be negotiating those difficult curves in the ED now in April 2020?
Yeah, I mean, I think that that's a great question. And, particularly in our patient population, if we know people are staying away from the ER, so we're going to see more and more of these patients. My approach is put them on BiPAP just like I would have before, aggressively titrate their nitrates. I mean, I can't tell you the last time I admitted somebody on BiPAP. Every one of them comes off BiPAP with the right amount of nitrates and afterload and preload reduction. And so I would go down that same pathway. The first person that I intubated was billed as CHF, and we did that, and she dropped her pressure in a very pronounced fashion with nitrates. And so I wonder if we're going to see more of that response of people that truly have COVID that are mimicking CHF are going to be more hemodynamically labile, but I don't know. But I would approach them the same way for now, with the expectation of getting them off BiPAP. And if they can't get off BiPAP, and we end up getting more data that maybe this is a patient with COVID, then I'd probably lean towards intubating them if they require that degree of support.
And another related question that came in is, can you clarify, and we've spoken about high flow, but what we do in the ED and how that translates into what is accepted on the various units or IMCs at each of our hospitals is not a one-stop answer. And so the specific question is one of our docs at one of our shops utilized high flow, but then tried to admit a patient who was a PUI on high flow, only to be told that we can't admit PUIs with high flow nasal cannula because of the concerns that we have spoken about in recent weeks.
Yeah, so we've seen this too, and this is part of the impetus to get a high flow nasal cannula protocol out there. Hopefully, this will change as we go forward, and every institute will have to come to grips with this themselves. But the document we have will have a reasonable protocol and a titration strategy, but also the kind of evidence or a review of the evidence showing that the risk of aerosolization with high flow is essentially the same as someone without high flow. And there's some evidence that's actually less aerosolization than those with a nasal cannula or a non-rebreather. So the hope is that once we get that kind of data and evidence out there, that there'll be less fear or hesitancy to take these patients. And we should certainly, I think in the ED, our tendency is to move towards CPAP and BiPAP because the patients we often see requiring that non-invasive support are CHF, COPD. And I think that should still be our first move, like Manish said. And then as you figure out more information, as they don't respond to your treatments that they normally would with CHF or COPD, and you're thinking that they might be something, a COVID or a true PUI, moving them towards high flow or transitioning them towards high flow is the way to go, because that's what will be used upstairs.
Well, yeah, and also, recognize too, a lot of the ones that I've seen, not all of them, but they're coming in with, temperatures of 40 or 39.8. Oddly, they don't feel, they tell you they don't necessarily even feel like they have a temperature. But so, also making sure, we're doing the right phenotype, right? That person, you're probably going to say, oh, this is not fitting purely CHF. And I think that, to me, high flow, I think potentially has a couple relevant uses. And one, I think it might be something that turns out to be helpful to either delay intubations, which may be helpful if we're using up all of our vents, because you're really essentially delaying, until that person can come off the ventilator who's in the ICU. It can also allow us to create a more sort of cohorted unit that expands our surge capacity for people that are sick, not quite sick enough in a surge situation to require ICU care, and they can be potentially monitored by people like anesthesiologists and hospitalists with sort of critical care on top of it. And then as they sort of decompensate off the high flow, moving on to sort of intubation and ICU. So I see it as a surge strategy, but I also do see it as a potential way of temporizing some people potentially through this disease, probably the younger, healthier people. But I think that, right now there's a lot of, just going back to, there's a lot of moving parts. This is a novel thing. And I think there's a lot of, rightly so, some fear around this through sort of all levels of the different providers and specialties and, ancillary staff. And so, I think we we just need to kind of make sure we're not taking away tools that are, that are tried and true for us, and, that we have all of our clinical tools in our bag, but we use them in the safest possible way. So, I think the high flow is going to look at, having a mask on the patient, being very clear that the evidence sort of supports that this isn't necessarily worse. And again, in our best thoughts, if we didn't have a lot of these patients, let's intubate them all. Let's reduce the aerosolization, early intubation, and then, we'll kind of go from there. That doesn't seem like it's going to be our reality anymore. And so we need to adapt to it. We just need to do it sort of safely.
I would, one of the points that Shay made to highlight, the nice and interesting thing about this disease process is it has a very consistent phenotype. They all come in looking fairly similar, and there's obviously going to be some overlap. But for the most part, they're febrile or feel febrile. They have the muscle aches, and then they have this hypoxia that, it seems out of proportion to their symptoms. And to me, for the most part, they look very different than CHF or COPD. I think we're also going to have to deal with the reality that so many people are going to get exposed to this. And what we're seeing with the data is there's people that have no symptoms. You have asymptomatic COVID patients. And so it's quite possible that eventually we'll have disease processes that you have someone with CHF or COPD that also happen to have COVID or test positive, but that's not the disease you're treating in front of you. And so you have to treat the patient that you're seeing. And if they look like CHF, we do everything we can to protect ourselves, but we treat it like it's CHF. And if it gets better from our treatment of the CHF, it was probably CHF, and they may test positive for COVID, but that wasn't the disease process that you were treating in front of you. I think that's going to be something that's going to be tough to grapple with going forward.
And along those lines, treating the what you see in front of you, a couple of different questions that came in preceding were regarding antibiotics. We see infiltrates on a chest X-ray. We see an elderly patient with comorbidities, perhaps. Thoughts about antibiotics, thoughts about blood cultures, thoughts about aspirin in suspected quote-unquote non-STEMIs. Where should we stand on all these issues? Because we certainly don't want to miss the typical disease that we see in our departments on a regular basis, and presuming everything, to your point, Rory, was everything is COVID, when even though it might be a COVID positive patient, it doesn't mean the disease process is COVID itself.
I think, like in most things in emergency medicine, and as the patients get sicker, you treat broadly and you kind of taper your treatment as you have more information going forward. But certainly a lot of these patients, it's going to be hard to differentiate COVID from a community-acquired pneumonia. So starting antibiotics up front is totally reasonable, and letting them be de-escalated going forward. Again, there's some of them that are slams dunks, that there's nothing else that can cause this. They appear generally well and exquisitely hypoxic and have a somewhat unimpressive X-ray. Those patients to me seem like COVID, and maybe you don't have to start antibiotics on them though. But I think a lot of patients where the story isn't so straightforward, starting antibiotics or treating them, as a broader patient or a broader differential is totally reasonable.
And to that point too, I also don't think we truly know enough about the bacterial co-infection chances here, because for a time the initial dogma was like, well, there's no co-infection with other viruses, specifically flu, and we sort of found that not really to be true in our early experience. So I think that there's a high risk for it. I think anyone getting admitted who has fever infection symptoms should probably have blood cultures, and so the way I've been approaching it is, if this is someone that, I would have given antibiotics to pre-COVID, then I'm probably going to give them antibiotics again. And the example that I use is like a 35-year-old who I might be necessarily sending home, with a fever and viral symptoms, but, they have a little bit of an oxygen requirement, so they can't go home. I'm sort of debating the antibiotics in that situation, right? But like last night, it's sort of a slam dunk 70-year-old requiring requiring oxygen, febrile, bilateral infiltrates, it's COVID 100%. Then, but I was like, if I was admitting this person pre-COVID, I would definitely be giving a 70-year-old antibiotics, right? And then bringing it in. So I don't know if that's right or wrong. That's sort of how I've been approaching it. But I do agree, like the general sentiment with Rory is it's always easier to, we were at a resident last time, we were talking about this. I always think that it's easier to sort of clear it up in the light of day. In 24 hours when you have more clinical data, you can always take the antibiotics away. It's a little bit harder to sort of add those on at that time. And all of our experience with all the data on antibiotics is it's sort of that early administration is what matters. So, I don't know what the right answer is, and I think that's probably a good panel question. But that's how I've been thinking about it in approaching it. I don't know what the right approach is, though.
I mean, I think that the data are relatively clear about patients in shock, and time antimicrobial probably matters in those folks. I would certainly say go broad in those individuals. The other ones I'm not so sure about. But I agree with what others have said. I tend to, if I would have given them antibiotics otherwise, I still do.
And I think one of the things that many of us are seeing, and a couple of the chat threads have come in and to address this point, is the phenotype for the admitted patients, specifically the IMC or ICU patient, is quite conserved. That's the reason that they're getting admitted to the IMC or ICU. But the outpatient, the ambulatory phenotype is actually quite variable with what we're seeing with the GI illness and other things of that nature, which has really been, I think, a surprising aspect for all of us. What we're seeing in the ED, what we're hearing from the urgent care centers, and just kind of the array of symptoms that COVID is having to varying degrees. And the GI symptoms were a particular, I think, surprise. It's certainly something that we didn't hear as much about. There's been a few studies that have come out of China, but it's really a profound, and some patients seem to be presenting with a diarrheal illness, an intestinal illness, with chills and with perhaps fever, perhaps a dry cough. So it's really it's really out there, and I like to say it's one of those diseases, illnesses. I think I mentioned this before, that if we don't think we're seeing it, it is certainly seeing us, right? So there's a lot of patients who have it that we to the point that everyone has brought up in this panel is that it's staring back at us, I think, more frequently than we even realize. But we're beginning to really recognize that. Some additional questions that came in. What do we think about obligation to work up other diagnoses? And I can tell you that I personally have received several patients where there was a concern for pulmonary embolism. There was a concern for I won't say more sinister, because certainly COVID in its sinister form is about as bad as anything, perhaps worse. But we've received a lot of patients, and that's the clinical concern. What do we do in that circumstance? What is the appropriate workup? And when, I guess it gets back to the antibiotic question as well.
I mean, there's no easy answer when you bring up PE in general, right? PE is the hardest diagnosis to make. I would say, again, the hypoxia you see in COVID is far different than the hypoxia you see in PE. Patients who have, most patients with PE who have hypoxia also have right heart strain. Because the hypoxia comes from the strain of the right heart, and either it's shunting, you're preferentially putting blood to areas where you don't have good ventilation, so you have some shunt, or you actually have some intracardiac shunt that otherwise wasn't diagnosed, and now that the patient has increased right heart pressures, you're shunting blood across that shunt. So it's a different physiology, and the patients who have hypoxia with PE tend to not look well, and they tend to be the sicker of your PE patients. So I think, for me at least, that would be kind of one of the areas I'd go away from PE and more towards COVID, when they overall look pretty well. Obviously, none of this is going to be definitive, and we're going to have to make these decisions. My fear is, as we start to think we can use our standard PE protocols to rule these people out, we're going to get into trouble. We can't really use D-dimer. A lot of our COVID patients are going to have elevated D-dimers in the first place, so that's not something we're going to be using. And if we think we can just order it on a bunch of low-risk patients to kind of rule them out, we're going to end up getting a whole lot of CT scanners on people with PUIs, which is going to shut down the CT scanner and cause a lot of issues. So I think this is going to have to be really a clinical decision that you're going to have to make, and there's a lot of responsibility determining when you go down that PE pathway, because most likely it's going to end with the CT scan.
I would say,
just to add to that, oh, go ahead, Manish.
Well, I was just going to say, if you're going to get a CT anyways, for the purposes of ruling out a PE, I think it's still reasonable to get a D-dimer in the hopes that it's negative.
Of course.
Because I think the negative predictive value is still there. It's just that it's more likely to be positive.
Yeah, and then just to add, I mean, again, as we're learning more about this disease, I mean, there was some sort of data that came out that, that this might actually be a sort of hypercoagulable disease state, that COVID sort of promotes hypercoagulability, and found, increased venous thromboembolism in some of the patients, and this is specifically out of China. So, I mean, I had a patient last night where I haven't seen the COVID test, but I mean, it was definitely COVID. Had bilateral PEs with some right heart strain. Looked like COVID, young person, probably has COVID, and definitely has bilateral PEs. So I don't know what the right answer is. I think it's sort of clinical gestalt, and and also recognizing that a lot of these people, they are going to be we're talking about people who are hypoxemic, right? So hypoxemic COVID is getting admitted, and if it doesn't start to make sense, potentially we can rely on our inpatient teams to sort of further work it up, because I don't think you want to light up the scanner for every single person, especially because there's a contamination concern too in the CT scanners, and sort of the cleaning process they have to do for the COVID. So we streamlined it, but it's still there, and it definitely adds a burden to sort of the flows of the department. So I don't know what the right answer is. I do think there's a signal in the hypercoagulability, because this seems like the worst disease ever. But I don't know how you work it up beyond just your clinical gestalt.
And a question that came in along those lines is, what about prophylactic anticoagulation? In the same way that you would give a dose of Zosyn and Vanco to the undifferentiated bibasilar infiltrates in a sort of a high-risk patient, would you consider not necessarily going to scanner, but a patient that doesn't have significant risk for anticoagulation in terms of prior stroke, hemorrhagic stroke, things of that nature, GI bleeding? Would you consider an empiric dose of Lovenox, for instance, that would at least buy a 12-hour period?
I think it all depends on the patient. In a certain patient who the risk or the phenotype isn't quite adding up with COVID, you put the probe on the heart and there's some right heart strain. And so, you more likely have your cause of hypoxia. It could be something due to some kind of pulmonary hypertension or PE. Then I think in that patient, sure, adding some empiric anticoagulation is not unreasonable. I think in the other patients, it becomes a little more difficult. Again, we don't know their reaction to anticoagulation. There is some suggestion that it might actually help them because they exist in this procoagulative state, and there's some thought that the downstream multi-organ failure is due to kind of microemboli throughout the circulatory system, and some of the path reports coming out shows that these patients die with microemboli in all their organs. So maybe it might be beneficial for COVID patients too, but right now we don't know.
Great.
And John, we didn't touch on the NSTEMI piece, which I think is a fascinating question. Many of these patients are coming in with elevated troponins and EKG changes, and I don't know what the right answer is, if we should be giving them some form of a platelet inhibitor, or whether or not we should be starting heparin or enoxaparin, and kind of when to call cardiology. I'd love to hear others' thoughts. I have a specific case where we weren't sure what to do, but I'd love to hear others' thoughts.
I mean, I still think you treat the patient in front of you. So if the patient looks like a STEMI or an NSTEMI, despite their COVID concerns, I think you still have to treat them as you would if before COVID or pre-COVID times. Again, because it's a possible hypercoagulable state, they may well actually have an interventional lesion that you could do something about. So despite COVID, I still think you have to treat them like they're an NSTEMI or a STEMI.
Great. And if I can ask Carrie Lehman to unmute if you're available.
Sure.
And so a specific question regarding ultrasound, and specifically bedside ultrasound in the setting of PUIs, cleaning, and recommendations from an ultrasound perspective. If we want to race in and do a POCUS study, what are the best practices?
Sure. Thanks to Carolyn Phillips, we've kind of compiled a list of ways to safeguard the ultrasound machine. So we are looking at obtaining clear sheath to cover the entire machine, as well as one to cover the probe. And the thought would be with that, you can still access the control panel and utilize the machine to do a look at the patient. And then we would remove that, throw it away, and then decon the machine with the purple Sanitop wipes at the places that still have them available. And then we have some other alternatives. We're working with supply chain in a central fashion to make sure that every shop has access to these types of covers.
Excellent. That's great. Well, I'm going to go ahead and wrap up our formal session. For those that are on the call, please feel free to stay on for additional questions. Thanks so much to Rory Spiegel, to Shane Kapler, and to Manish Goyal, all members of the MedStar Emergency Physicians section of critical care, newly formed, and I tell you, couldn't have formed at a better time, right, with everything that's happening in our world these days. And so for everyone that is watching this afterwards, be safe, be well, and we'll look forward to another pop-up learning session in coming days. Thanks so much.